Maybe you are live now.
Background in the chat box.
Okay, welcome everyone to this AIOS Masterclass today. This is again in the same series of Masterclass that we have. And today we have AIOS Masterclass by none other than Dr. A.K. Grover sir, who's actually teacher of teachers and master of masters. And the topic is all that you wanted to know about eyelid repair and reconstruction. It is a privilege to introduce Sir, who actually needs no introduction. He's very well known to all of us. He's the recipient of the prestigious Padma Shri Award by the Government of India. He's the president of Oculoplastic Society of South Asia, president of the Ocular Trauma Society of India, and counselor at large of the Asia Pacific Academy of Ophthalmology. He's the past president of All India Ophthalmological Society, Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery, and Oculoplastic Association of India. He has keen interest in the field of ophthalmic education, and as president of AIOS and chairman, Academic and Research Committee, he has been instrumental in the formulation of several of the landmark things, one of which includes the formulation of the postgraduate and subspecialty curricula for the society. He was the architect of the annual CME programs in all 5 zones of India, which have been running successfully for nearly a decade. He was instrumental in creation of the headquarters at the All India Ophthalmological Society in New Delhi as the chairman of the committee. He serves on the editorial board of Asia Pacific Journal of Ophthalmology, Indian Journal of Ophthalmology, Journal of International Medical Science Academy, and is reviewer for several international national journals. He's also an examiner for the FRCS Glasgow, and more recently, his own center has been recognized as a center where the exam for the FRCS is going to be held. He's a recipient of numerous prestigious awards and orations, including the Distinguished Service Award from Asia Pacific Academy of Ophthalmology, Honorary FRCS, Honorary Fellowship of International Council of Ophthalmology, Colonel Rangachari Award for the Best Paper from AIOS, and numerous international and national orations. He has authored, edited 5 books, written over 100 chapters in textbooks, and has over 60 peer-reviewed publications and over 1,100 presentations at international and national level. He's chaired sessions and been a guest speaker or performed live surgery all over the world, including the World Congress APO, Afro-Asian Academy, American Academy of Ophthalmology, British Oculoplastic Surgery Society, APSO PRS, and several other international and national meetings. I would now request Dr. Rajesh Sinha to introduce our esteemed panelist, Dr. Lakshmi Mahesh ma'am.
Thank you. Very good morning to all of you. It is my privilege and honor to introduce somebody who is well known in the ophthalmic fraternity all over, Dr. Lakshmi Mahesh, who is an expert in ophthalmic plastic surgeon. She is recognized internationally with 29 plus years experience in the field. She is a pioneer of endoscopic lacrimal surgery in India. Most recently, she held the esteemed position of president of the Oculoplastic Association of India. Over the past 2 decades, Dr. Lakshmi has received many invitations to present papers and conduct instruction courses at premier ophthalmic conferences all across the world. She received the 2011 AIOS APOS Santosh Honawar Award for Best Paper in Lacrimal, the 2015 AIOS Sujata Savitri Rao Award for Best Paper in Orbit and Oculoplasty, and the prestigious FICO from AIOS. Dr. Lakshmi was invited to serve as a visiting scholar to the famed Chinese University of Hong Kong. During this tenure, she trained doctors in Hong Kong and China and traveled to provide surgical care to patients in hospitals across locations in mainland China as well. She is a great leader and a wonderful teacher. She uses state-of-the-art techniques and knowledge to care for her patients, and she has trained more than 30 fellows in India and abroad in the field of oculoplasty. She is also a reviewer for many ophthalmic journals and a subspecialty society representative for Indian Journal of Ophthalmology, that is IGO. It is really a great pleasure and honor to welcome you, Dr. Lakshmi. We welcome you in this webinar.
Thank you, Rajesh. Myself, Dr. Namrata Sharma, Honorary General Secretary of the AIOS and Professor at RP Center of AIIMS, New Delhi. And I have with me my co-moderator, Professor Rajesh Sinha, who's the Honorary Treasurer of the All India Ophthalmological Society and is Professor at Cornea, Cataract and Refractive Surgery Services at RP Center, AIMS, New Delhi. So without much ado, we would request Dr. Ashok Grover sir to please give his masterclass on all that you wanted to know about eyelid repair and reconstruction.
Thank you, Professor Namrata. I'm grateful to the All India Ophthalmological Society for this singular honor of being a speaker in a masterclass for the audience of the All India Ophthalmic Society. And particularly to Dr. Namrata, Dr. Rajesh, also grateful to Dr. Lakshmi Mahesh, honored and very respected name in the field of oculoplastics, for joining us in this discussion, which will add a lot to the value of the program. Always a joy sharing discussions and interaction with the audience of All India Ophthalmic Society. And it will be a privilege to discuss a subject which I love and I have a lot of passion for: eyelid repair and reconstruction.
Can I just say a word, sir, before you start?
Yes, Lakshmi.
Namrata has given a beautiful description about all your achievements. I don't have anything to add on that. But as far as OPI is concerned, Indian ophthalmology scene, she has told you, but as far as OPI is concerned, you are a big pillar in OPI. And it's not here I'm come to just moderate or whatever, means what. So I'm having a notebook. See, I'm going to write down what you're. I'm here to learn as well. Thank you.
My privilege, Dr. Lakshmi. You have been a source of strength to all those who are interested in the field of oculoplastics. So I thought the eyelid defects are a huge challenge to oculoplastic surgeons, and the kind of problems that we face in India, where we are presented with people who come late and who come with huge tumors, it's always a major challenge, and you often have to take the road less traveled. We will discuss two aspects of eyelid repair and reconstruction: repair in cases of eyelid injuries and the management of eyelid defects. Some aspects are common in the two, and we will share those with all of you. And I would love to have discussion from any of you, Dr. Lakshmi, Dr. Namrata and Rajesh, at any stage, and from the audience. It'll be a privilege to have any of your questions in the chat box or ask questions which we can all address at any stage. So let's look at the eyelid trauma. In eyelid trauma repair, we are going to look at what the objectives of repair are. We look at the appropriate timing and the various options at different timings. We look at the wound management of the various aspects like lacerations, injuries to the levator, injuries involving canthus, and more particularly, the injuries to the lacrimal canaliculus. When we want to repair an eyelid, it is first and foremost to restore back the anatomy, which is essential to restoring the function. And on the face, restoration of aesthetics is an equally vital aspect, because this has a huge bearing on a person's confidence and his ability to face the world. Most preferred is the primary repair, the repair that is carried out within the first day or first 24 hours when the patient comes with the injury, because this offers us the best opportunity to bring back, align back the tissues without causing any deformity and bringing about the best anatomical and functional results. Where the patient presents late, we often wait for controlling edema and infection before carrying out a delayed primary repair within the first few days. But if the patient presents even later, or with a previous repair which has been misaligned or delayed then you may require a secondary wound repair to take care of the sequelae. We prefer to wait for a period of about 6 months before carrying this out, when the tissue reaction and the tissue sensitivity have subsided, and allows you to carry out the repair without causing too many sequelae of fibrosis. Now, the primary repair, the important considerations are the anesthesia. Most procedures can be done under local anesthesia, except if they are to be done in children, or they may involve the globe as well, or delicate structures where anesthesia may impair the carrying out of the procedure, like sometimes in canalicular repair. It is important to take care of the hygiene of the wound well, to remove all contamination, give an adequate lavage with saline and particularly with betadine in order to reduce the chances of infection and inflammation before you carry out the repair. Let's now look at the various aspects of wound management. Of course, antibiotic prophylaxis, anti-inflammatory cover, enzymes, and tetanus toxoid go without saying in the preparation up to the wound management. Now, we look at the repair of lid lacerations, particularly when the margin is involved, which makes the repair very critical. You also need to identify the injuries to the levator and make sure you reinsert or reattach them, because this will ensure prevention of severe ptosis, which can be extremely deforming. Management of canthal injuries is particularly important, as the sequelae of poorly managed canthal injuries can be very deforming and very traumatic functionally. Canalicular injuries are special considerations because lifelong epiphora can be extremely troublesome. Simple lacerations like these can be managed with good apposition using fine sutures under magnification with eversion of edges. Interrupted sutures are usually the best, and non-reactive materials like nylon 602, 70, or 80 are ideal for this repair. However, when the lacerations are more complex, they may require putting back the tissues to the best of our ability, like a jigsaw puzzle, making sure that the tissues fall back into their right positions. However, there can be occasions when there is loss of tissue and you need to advance a flap or use a graft for the tissue loss. Primary management usually on the face is extremely rewarding because of the rich vascular supply, and you often are able to avoid any debridement of the necrotic tissues. Just the removal of all the contamination and bringing back the tissues usually works. Grafts, as far as possible, are avoided at primary repair because of contamination and risk of infection, but where necessary, epidermal or even a full thickness graft may be undertaken. So let's look at the technique of marginal repair, which is vital. Sutures such as 60 nylon or 60 silk is used, and what you've seen is a vertical mattress suture which has been placed just posterior to the gray line in firm tissue. The second suture is being placed more posteriorly, close to posterior margin. First bite 3 mm from the cut edge, 3 mm depth, coming back to the same side 1 mm from the cut edge and 1 mm depth, giving a vertical mattress suture which causes eversion. The third suture is being placed close to the lash line. These three sets of vertical mattress sutures ensure that there is a very good apposition, a slight pouting of the edges, and a near perfect wound repair. Next, the tarsus is repaired using absorbable material like Vicryl. 6-0 Vicryl can be excellent. It is usually done as a partial thickness repair to avoid any irritation on the inner aspect. Once the closure of the tarsus has been carried out, skin closure is then carried out with the 6-0 nylon sutures and gives a good repair. It is important to learn this technique as it will be used in trauma repair, in lid reconstructions, as well as in a number of cases such as ectropion and entropion. As I said, the results on face can be extremely gratifying because of the rich vascular supply, and you can get back results that are really wonderful. Levator injuries are to be suspected whenever the preaponeurotic pad of fat is exposed. You need to identify the levator, put it back on the tarsal plate, and suture together with 6-0 Vicryl sutures in order to ensure that the function of levator is optimized. Levator is a resilient muscle. If you put it back, the function returns very well. And primary repair offers the best chance of carrying out this repair. We'll also stress on the medial canthal and the lateral canthal tendon injuries at this stage because they are critical. In the medial canthus, you have the anterior crus of the medial palpebral ligament and you have the posterior component of the medial canthal tendon. Now, the posterior crus of the medial canthal ligament is critical as avulsion or breakage of that particularly leads to bad telecanthus and displacement of canthus. So you can see a Proline suture being passed to repair the posterior crus of the medial canthal tendon. What is important to remember is that usually a canalicular injury is associated with these medial canthal trauma and needs to be repaired well. Also, that the posterior canthal tendon is attached behind the sac at the posterior lacrimal crest, and that is where all reattachments must be done. Where a suture through the periosteum at medial canthal tendon is not possible or not strong enough, then you need to carry out a microplating or transnasal wiring, which we will look at when we look at the repair and reconstruction in the medial canthal region during the eyelid defect management component of it. The lateral canthal avulsions also need to be tackled well to ensure that you do not lose the nice, fine, acute angulation of the medial canthus. And a rounding up or a medial shift of the lateral canthal tendon can be a deforming thing. So here again, we are using a 4-0 firm Proline suture because it's a permanent suture and using a double arm suture to anchor it to the lateral orbital rim. Now, the important thing in this anchorage is that the bite must start behind the lateral orbital rim in the periorbita and then come out anterior to the lacrimal crest at the point of the lateral tubercle or Whitnall's tubercle. And this ensures not only a proper angulation, but a proper position of the medial canthus tendon. So lateral canthus is now being repaired here with a vertical mattress suture at the lateral canthus after its fixation to the lateral orbital rim. At times, you may need to drill holes through the lateral orbital rim and pass sutures such as Proline if periosteal sutures are not possible. An example is a medial and lateral canthal tendon avulsion, as in this case, which has been repaired, and this is at the end of the procedure. So an early meticulous primary restoration of anatomy is the key to success in the management of trauma to the adnexa. Before we go on to canalicular injuries, I would like to hear Dr. Lakshmi tell us about what she would like to supplement on this and what her experience in this aspect is. We'll then take any questions from the audience also for this aspect before we briefly speak about canalicular injuries.
Yes, sir, you have meticulously described, and actually, this is a wonderful class because it's time and you're going very well step by step, and you've also emphasized a very important point of when there is fat prolapse to look for a deeper injury, deeper fracture, or something like. So, I think in cases, especially in the lower lid, if there is fat prolapse, I think a CT scan will also help to make sure that we are not dealing with a bad fracture, and maybe deal with the fracture repair later after doing the step-by-step meticulous repair of what you have described. So you have beautifully put it in a gist of debridement, identifying the anatomy there, if possible decrease the edema, if not at least to put back things together and later take care of some other smaller uh, setback which is there, which is bound to be there in extensive injuries at a little later stage. Thank you, sir.
Thank you, Dr. Lakshmi. We'll welcome any comments or questions from the audience. Please put them in the question box or chat box, and we'll be happy to discuss them. Dr. Lakshmi will take them up for us, and the two of us can discuss them. Now, a special consideration is when the lacrimal canaliculi are involved, because it is critical to manage them in appropriate time, and because a delay is the most important cause of failure of canalicular repair. The canalicular injuries are often very obvious. If there is a cut at the medial canthal region, which is inert punctum, it will be obvious. But there are times when it can be relatively hidden. These are the examples of the obvious ones where you would, of course, undertake a reconstruction of the lid and carry out a canalicular repair. But sometimes it may look as occult as this, where there is a minor cut. This was a cut with a blouse hook, and all that you need to do is put a probe through this and you'll find that it is coming out through the cut end. And these will need repair, otherwise there will be a fibrosis and closure of this passage. So look out for these occult ones, have a high index of suspicion. Now, the eyelids involved in canalicular laceration are most often the critical lower ones, 72% in a large series, 16% in the upper lid, and both injured in about 12%. Early repair within 24 to 48 hours is the most desired result. However, it has been shown that if you are able to repair within the first 5 days, you have a very high chance of success, and fibrosis does not really hamper the results. Now, what are the principles of repair? It is important to identify the cut ends, to put them together. You must approximate them and carry out a stenting. Now, stenting implies that you pass an inert structure through the lumen, which will ensure that the patency of the tube is retained without fibrosis extending into the lumen. And for this, it is important that the stent is retained for an adequate period of time. We'll see what that adequate period of time means. Now, there was some question where some people used to prefer general anesthesia. When we were doing our residency, that was the teaching, because identification of the cut end can become difficult once you've injected too much local anesthesia in this region. But with the ease of availability of microscopes and better visibility and illumination, most cases are now done under local anesthesia, and some of the simpler techniques have now been devised. So as I said, one critical aspect for the repair is localizing the medial cut end. Lateral end is, of course, easy. You pass a probe through the punctum, it will emerge through the outer cut end. is the medial cut end, which is critical. And this is more difficult the more medial the cut is, because then the canaliculus has shifted more inferiorly and deeper into the eyelid tissue. And that is where identification is important. Now, what is most important is that once you've seen a few, you can recognize the appearance of a shiny white cuff of rolled out edges of the canaliculus. It is a much larger structure than you think, and it's easy to identify it. So once you pass a probe in its normal anatomical position, keeping it like this, you can often see that it would end up very close to the medial cut end. And under magnification, once you retract these tissues, you will be able to see that. If you're not able to see that, then Morrison's method is very useful. So what you do is you put a pool of saline here. You take a large 10 ml syringe with air, inject air through the upper punctum with a large syringe, block the area of the sac by putting a finger there, and see the air bubbles emerge from the medial cut end. Now, you may not always be able to see that area immediately. Put a traction suture in front of it, maybe an 80 nylon of the area where the air is emerging from, and pull it towards you. Once you pull the tissues, you will be able to see the area from where the air is emerging. Now, there are alternative methods using dye or milk through the opposite punctum. Sometimes you can use a diluted trypan blue for this purpose, or fluorescent for this purpose, which will not be thick enough to stain the tissues. And one of the methods which was in great use earlier was a pigtail probe, where you pass the pigtail probe from the opposite punctum to emerge at the medial cut end. But it is less popular now because of the risk of injuring the uninvolved normal canaliculus. Morrison's method works well for all difficult cases, and I would highly recommend this to everyone. Now, what are the stents used? Most popular is the mini Monoca, which we will see, a self-retaining stent of silicone, easily available and available at a reasonable cost because it is now manufactured in India. There was a time when this was difficult to get because of the high cost of the imported one, and we were all forced to have alternative techniques. And when we started our career, of course, there were no stenting materials used. We often used Proline sutures, or we even used silicone tubes imported from abroad with stainless steel stillets of stainless steel 26, 24 gauge needles put in that as a support. But now we have enough of good materials available. Bicanalicular intubation sets such as Crawford, etc., can very commonly be used. And in difficult situations where you have none and you can repair it well with a Teflon intracath cannula, a technique we described in 1986 in the Asia Pacific Academy of Ophthalmology held in New Delhi. Now, the surgical technique involves stenting, as we said, which may be monocanalicular, as you see here, or bicanalicular when you use a Crawford stent. A pericanalicular suturing is important. What is important to see is this word of pericanalicular. So you make no effort to go in or at the lumen of the canaliculus. You suture the tissues around with a material such as a 6-0 or 8-0 Vicryl, and then carry out a marginal repair as we've already learned. Now, there are simpler techniques that have now been described where you just put a single suture around the canaliculus to oppose it while ensuring that your mini Monoca stent is in place. So which is the stenting, reliable stenting has made it much easier to carry out simpler anastomotic techniques such as these techniques that are now described. So let's look at the technique in a relatively more complex case. They're using the Teflon thing, but we'll show you the mini Monaca stent as well. So this is the punctum, as you can see. So we are enlarging the punctum a little bit with a single snip in order to enable the stent to go in. Now, this is the Teflon tube where we have cut out the needle component of it, and we're using the inner core as a stent, and it has gone easily through to the bone through the inner opening of the medial cut end. And this is a suture which has been put around it. Sutures can be placed at 3, 6, 9, and 12 o'clock position, or a couple of sutures can be placed to oppose the walls of canaliculus, and then a marginal repair by the standard technique that we discussed can be carried out. So as you saw, identifying medial cut end, putting in a stent, either mini Monaca or your intracath here, if that is not available, then a marginal repair after putting a couple of pericanalicular sutures with 80 vicryl. These are the essential steps. But as we emphasized earlier, it is the medial cut end identification that is important. So we had a second cut here at the margin, which we are repairing. We are also repairing the conjunctiva in order to get an apposition of all the things. Now we have this end left here. Now this can get extruded out very easily. So we are fixating it with a double arm suture by passing it through the tube and then through the skin of the lower eyelid. But this we found was not adequate, particularly in children, as it still had a vector outwards and could get exposed. So we gave it another bite from the skin and came out more medially with both the arms of the suture. After it has emerged on the skin here, take another bite for both of these sutures through the skin and take it out closer to the medial canthus, tie it on a bolus. Here we're using a simple IV butterfly polythene tube for this purpose. And this would ensure that there is a vector inwards and this tube will not get extruded out even in children. So how long do you retain it? A period of 6 weeks is often spoken about now as the ideal time. Anything more than that is not productive because you start getting a biofilm around the tubes and you start getting punctal pouting and so on and so forth. So usually 6 weeks is considered more than adequate. So let's look at the mini Monaca tubes. Here we are putting in, this is the cut that we have. We've identified the medial cut end. It's very close by. We've again done a single snip and introduced the mini Monaca tube. Now, the important thing about the mini Monaca tube you'll see is how easily it can be self-retained at the punctum and does not require that elaborate exercise of fixing it. So this has this deeper knob which goes in and the outer collar that remains on the surface of the punctum. Now, sometimes in children, you may want additional security of a single suture or vicryl to fixate, but usually 99% of the times you would not do it. So this is a good self-retaining mini Monaca stent. Fortunately, the results are extremely gratifying, and if done early enough, the results in our series have been 97%, which is in line with most other people. Complications of extrusion, cheese wiring, granuloma formation around that, a hematoma or infection are relatively all infrequent. So before we go on to that, Dr. Lakshmi, any more tips that you would give or any questions from the audience that you may have seen which we can address?
Yes, sir, there are some questions. I think it's better to finish them before we go on to your next set of descriptions. Dr. Anand Sethi wants to know how you identify the posterior lacrimal crest in medial canthal injuries? He wants to know that. So, and there are two more questions after that, sir.
Okay.
So even it's not an easy
yes.
task at all, especially when there is edema. So how would you go about it, sir?
So it's usually important to give a separate incision in the medial canthal region, anterior to the lateral to the caruncle, and then direct your scissors posteriorly behind the position of the sac. Now, and carry out a blunt dissection with that needle, with that scissors. If you know the direction of the sac and position of the sac, and you direct your needle, you direct your scissors, open it, use it as a dissector, you can easily feel the position of the bone behind the sac. And that is where the posterior lacrimal crest lies. So a good exposure is necessary for being able to carry out attachment to the medial canthal tendon, and use of a headband light is very important. If you have a little magnification, a 2x or a 4x, 3x loop, and you have a good magnification, and you have a good lighting which is directed in the right direction in the depth, then you can easily locate the posterior lacrimal crest by giving an incision. It often may require a separate incision to be given in the conjunctiva to get to the posterior lacrimal crest. Identify that, feel the firm posterior lacrimal crest, and then carry out the repair. Yes, this is a technically demanding job, but it needs to be done. And sometimes when there is a bony problem as well, sometimes when there is a bony problem as well, you may need to use even a microplate. Yes, Dr. Lakshmi.
Yeah, but my modification of his question is, supposing the sac is intact, do you want to disturb the milieu of the lacrimal sac and then go there? Or would you just want to just leave it off by anchoring the canaliculus alone?
Fortunately, since you are in a plane which is going posteriorly, you are not altering the functionality of the structure, which is going posteriorly. So you are able to avoid any damage to the lacrimal drainage apparatus by that. So it's just the direction, getting the hang of the right direction to go downwards and somewhat medially.
So I think Dr. Anand Sethi can please respond by a message as to whether his doubt is clear. Dr. Prashant Reddy wants to know dog bite injuries, especially in children, how you manage both medically and surgically. In fact, that question has been going on for the last few days in my mind also. Because these days they say in dog bite injuries, you have to give the ARV at the site of injury. So it's very important when it comes to the eye. So how do you manage, sir?
Now, important thing is that the dog bite is in the face region. So it is a dangerous area. But primary repair, there was a question whether a primary repair should at all be carried out or not carried out in view of the risk. But increasingly, people are doing a primary repair. That's the consensus now. But after a very good wound hygiene, including the complete prophylaxis for rabies, including the serum, including the antibodies to be given immediately besides the vaccine. So you need
come across any paper where they're giving injection to the eyelid area, sir, in dog bite injuries? I have not come across so far any.
No, I haven't either. It's
so
just the irrigation.
In the periocular area somewhere, the ARV, because I have to look up on that point. I think that one question we'll have to look up. So, so you mean to say that you would like to take up the case as early as possible with the thorough wash and
that is the consensus now in dog bites. Primary repair is carried out now after a very thorough irrigation and with complete prophylaxis, including the vaccines, including the serum, in order to get the immediate antibodies as well.
So the only question is, where are we going to give the vaccine and serum in addition to the, of course, the intramuscular? Now, Dr. Rajdeep Bishwas wants to know, do you use 60 Vicryl for lid repair?
Now, marginal repair.
Wants to know that because I think we use, but what's your opinion?
Marginal repair, I find 60 silk very comfortable because of the softness of the material. So we have very little risk of causing injury to the cornea if a suture end comes inwards. But 6-0 nylon is equally comfortable, but you only have to make sure that you have all the three ends tied together in the anterior most suture, all the long ends, so that no end is rubbing against the cornea. 6-0 Vicryl is also comfortable, but I think the needle is a little smaller than 6-0 silk, and that makes it technically a little more difficult. But whatever you find most comfortable, you only need a strength for about 2 weeks. We retain those sutures for 2 weeks, and Vicryl would also give you this strength for 2 weeks. And so I don't think.
Small hitch here. So, do you want a braided material for the margin, or because you also mentioned nylon, or you don't want a braided material? Means you would prefer a non-braided
material. In fact, is an advantage. 6-0 silk, in fact, gives a little extra reaction, a quicker healing. Yes. A material which is as monofilament like nylon would cause less reaction and would not induce additional healing.
Yes. So for margin, you would still prefer a braided material.
Yeah.
Okay.
So Vicryl is a fair choice if that is what you have.
But as the lesion, the wound goes medially, you don't mind an unbraided material as well. That is the monofilament as well.
Yeah.
Okay.
Yeah.
Thank you, sir.
So we'll go on to from trauma to eyelid defects. So repair and reconstruction of the eyelid defects is the next aspect. Now, these eyelid defects are either congenital or acquired. We'll talk about the indications that we come across for eyelid defect management. We look at the basic principles. We look at the evaluation that we need for decision-making regarding our management. And in management, we will particularly look at defects that do not involve margin, defects that are full thickness and involve the margin. We'll particularly look at the techniques and the principles of use of flaps and plasties in eyelid reconstruction. And then we will look at canthus reconstruction, which we promised when we were talking about trauma to the medial and lateral canthus. So these are the things that we're going to discuss one by one. Now, one of the common indications for repair to us is congenital colloboma. Much less commoner than acquired causes. Congenital collobomas are relatively rare. And you have these upper lid collobomas, which may be of different size, usually at the junction of outer 2/3 and inner 1/3 of the eyelid. And if they are small to moderate, they often do not cause any exposure keratopathy and can be repaired at a period of your choice. But there are those which are symblepharon variants of cryptophthalmos, which are associated with larger collobomas and with eyelid skin running onto cornea. These are often bilateral, sometimes as a part of Fraser syndrome, or sometimes as a part of golden heart, and sometimes as such. And these are often associated with exposure keratitis and may require repair in early infancy. Lower lid collobomas are rarer. They may be part of Treacher Collins or of various facial clefts and can wait for repair to an older age group when the tissues are better formed at the age of about 5 or so. Now, the acquired eyelid defects most commonly need to be repaired are those which are due to the collobomas that we create for surgical resection of tumors. Then there are these traumatic cases, including burns and irradiations, or iatrogenic, where we've done a surgery and caused some necrosis and loss of tissues, as was earlier common with entropion repairs with clamps causing avascular necrosis and so on. Now, looking at the principles, we have to identify the structures that constitute the lid. Whenever we do a reconstruction, we need to think of lid as two entities, two lamini, the skin muscle, the skin subcutaneous fat, and the orbicularis oculi. This is one unit, integument on the surface, and the inner lamina, which is a mucosa, that is conjunctiva, with a strong support, which is provided by the tarsal plate. Of course, the inner lamina is also constituted by the levator, aponeurosis, Müller's muscle, and so on and so forth. So these two lamini both need to be there for a reconstruction to provide a smooth lining, to provide the functionality, to retain the blinking, identify the special characters of the lid. The upper lid skin is very soft and supple, which allows the lid fold to form, which allows the blinking to take place. And you need to retain many of those characters as far as desirable or possible. And the inner lamina, besides mucosal lining, if the defect is small, you can avoid additional support because the rest of the eyelid tarsus will support it. But if it is large, then you need to provide the support as well, which we will look at when we see the details. So the principles of eyelid repair are, think of it as two lamini, anterior lamina and posterior lamina. Important thing is that at least one lamina has to have an intact vascular supply. If I have an inner lamina taken with tarsoconjunctiva with intact blood supply, I can put a free skin graft here. But if I have a flap, I would prefer that because that is also with vascular supply. So this essentially constitutes the most important principle of eyelid repair. Dr. Namrata, any would like to know whether a comprehensive ophthalmologist can follow any of what I'm saying?
No,
That
sir, they can follow. And there is a huge number of audience which is there at the YouTube as well as at the Facebook. And there are a lot of questions also there. And I think it is very appropriate.
So can we take up the questions now before we proceed further, if they're pertaining to the trauma part of it?
Yes, so we can take up the questions. The questions, I think, Doctor, there are a lot of congratulatory notes also which are there. And Dr. Sumit Washne wanted to know, is there any benefit of using Proline suture for lid repairs?
Yes, we use Proline exclusively for those things where we want a permanent anchorage. Say, for example, or a long anchorage to be present. Say, for example, at the lateral canthus, at the medial canthus, or for tightening of a medial palpebral ligament, or wherever, or a transnasal wiring, or wherever we want the effect to last long, because it has the advantage of permanence with little reactivity, hardly any reactivity. So that is the reason why we would prefer a Proline suture in those situations. Even sometimes we use it in a Whitnall sling ptosis procedure where we want the effect to be long lasting without any reaction. That is the situation where we would use Proline suture.
So there are a lot of congratulatory messages. Just to name a few: Dr. Puneet Dubey, Dr. RHS Nagpal, Dr. Maurya, your good friend from Banaras, Dr. Puneet Islor, very nice talk, sir. Dr. Rajendra Prakash Maurya, excellent talk, Dr. Grover, sir. So there are a lot of congratulatory messages which are there on the Facebook, and people are watching. I think we can go ahead, sir, and then we can take up the questions.
Thank you all for your love and for being here for this session, which I'm enjoying doing with all your participation. Hope there is something useful that we can bring about. So we've spoken about the principle, but when we come to the actual management, we need to assess what the defect is like and what therefore would be the planning for reconstruction or repair of the defect. So first and foremost is the upper or the lower lid. Here, as we know, the upper is the more vital one for protection of the globe. And as a general principle, Mastarde repeatedly stressed that please do not use upper lid for lower lid, because you do not want to compromise on the upper lid. But of course, as we have come to use these tissues more and more often, we know that we can use upper lid as well for the lower lid, but it is important to recognize the principle that Mustard is stressed. Now, the level or thickness of the defect is again important, whether it is partial thickness or lamellar defect or a full thickness defect, which would have a bearing on the management, as we'll see. Is the margin involved, and is the marginal repair required, where we need to specially identify the principle? Size of the defect will have a big bearing on how you choose to repair the defect, and we will again see this as we talk about the management. And the shape of the defect. Now, why is the shape defect? Because some shapes, like a pentagon that you deliberately create, are most likely to give you the best possible apposition and alignment. And we often convert those shapes into desirable shapes by additional resection of tissue in order to get a correct repair. Now, under the management, we are going to look at non-marginal partial thickness defects first. Then we look at full thickness defects. And as we said, its size is going to matter. So up to 1/4 will be one group, a little more than 1/4 or more than 40% to nearly 2/3, we'll look at the techniques again. And then near total defects or more than one eyelid involved, these require a special technique. So we look at these then. And of course, the lateral canthal and the medial canthal defects all require special consideration. Now, let's look at the partial thickness defects. So you have these xanthelismas here and a xanthelisma here. So what do? You excise, but you make sure you excise by converting them into ellipses. And along the, you would all have heard of Langer's lines in our Love and Bailey days in general surgery. So they are along the direction of the fibers of the muscles or tension lines. So we have the orbicularis fibers here in this line. So these are always horizontal wherever possible, wherever there is enough tissue laxity to allow for it. And if these can be opposed without any tension, then that is the ideal closure. In the upper lid, this principle always holds, and almost always all incisions are parallel to the eyelid margin, as you can see in the xanthelisma, converted into a blepharoplasty incision and easy closure. In the lower lid, this principle is altered, because what becomes very important is that you do not cause any pulling down of the eyelid margin. So you would like that pulling down force to be least in the vertical meridian. So if I have a lesion like this, I would incise it like this and not like this, because this would mean pulling down of the margin and causing an ectropion. So a closure in a vertical fashion after a vertical spindle excision would be perpendicular to the margin, and this would be the repair in lower lid. Now, if the defect is large, in lower lid particularly, you do not want any ectropion, so you need to supplement with tissue, like the use of a graft, or an example is this kissing nevus, where you have this skin defect which can be excised and skin replaced with a thin skin graft. So this would compensate for all the loss of skin. Sometimes you can take a flap, like this advancement flap drawn from the lateral side to remove this keratotic lesion here. And this flap has come in. You can't, in the lower lid, excise it and close it, because you would then cause a outturning of the margin, outturning of the punctum and epiphora. So that is what we essentially do for partial thickness defects. And this involves early basal cell carcinomas. We don't really get early basal cell carcinomas which are not close to the margin as much as in the West they do. And many of their repairs are what we have seen with flaps from various parts. We need to use those flaps much less often because we do not get those early cases. Now let's look at the full thickness margin involving defects, which are what we commonly encounter. And Dr. Maurya has a lot of experience in dealing with huge tumors because he gets a lot of patients from the rural areas in Eastern UP who have a massive tumor before they come and require massive reconstructions. So this is an example of a full thickness margin lid defect. So up to 1/4 of these defects can be repaired by direct layered closure, by direct suturing that we spoke about. Now, the important thing we'll see is to have pentagonal defects. But if you have a defect of up to 30 or 40% in older patients who have a lot more laxity, you can easily still do a direct layered closure. And if you need even more laxity, then you do a lateral canthotomy and opening up of the crust on that lid, which we will see in a later video film. So let's look at the excision. So this is a basal cell carcinoma, a 3 to 4 millimeter zone all around. And this is the pentagon that we define. This is an elderly patient up to about 35% defect. This can be easily repaired by this direct closure, and you have a good apposition, and there is no excess tissue left. So you can see the repair is adequate. We did not need a lateral canthotomy or cantholysis in this. Now, when it comes to anything more than 30-40% to 2/3 of the defect, then you need supplemental tissue either from the lateral side or from the opposite lid. Now, this may mean using just the skin flaps, or you may need inner lamina as well, or you may use both laminae from the opposite lid. So lid sharing procedures can just use the inner lamina, which was called the Hughes flaps, and the Cutler beard flap is when you repair a defect in the upper lid by taking both inner and outer lamina as shared tissue from the lower lid, and inverse when you use that for the lower lid from the upper lid. And then, of course, there is the Mustardase flap, which rotates the full thickness of the lower lid from lower lid to upper lid. Particularly, Mustardase does not advocate rotating the upper lid to lower lid. So lower lid to upper lid, full thickness flap. We'll look at all these techniques. So these essentially are the common techniques that we use in the, and of course, skin grafts wherever necessary for 1/2 to 2/3, depending on the location, depending on the size. So let's look at the tensors repair. It will highlight several other principles. Now you see, we have converted this defect into a pentagon. This is a congenital colloboma. We need raw edges. So we are giving this incision and converting these defects. Each of these is perpendicular to the margin, the two margins. And then this is a pentagonal shape, goes up to the upper border of tarsus, then converts into pentagon. Now this is created for the upper lid with a curvature, with the convexity downwards, for the lower lid with a convexity upwards. And then we are doing a lateral canthotomy and cantholysis and undermining of the skin for the flap. Now see, this is where we are detaching all the attachments of the upper lid to the lateral margin, that is cantholysis, which has freed this lid to move inwards now. Now this remaining part of the eyelid can move to become the central part of the eyelid where the lashes are necessary for aesthetic reasons. And then we are carrying out a repair of the margin as we had discussed, repairing the tarsal plate and then repairing the skin. Now reconstituting the lateral canthus is critical. So see, this suture is a vertical mattress suture, has come from the lower lid at the depth and then coming out more superficially. So it becomes a vertical mattress suture, closing the canthus at the right position. This will be anchored to the lateral orbital rim. And then we'll close subcutaneous sutures areas. We'll close the skin. And we will ensure that the fornix is adequately deep here by passing 2 fornix forming sutures and tied over a bolster. So this is essentially a Tenzel's repair. So this is eyelid Colloboma. You can see the defect of the eyelid here and a misaligned lateral canthus. So we've opened out this lateral canthus and we have made for the upper lid convexity down incision reaching up to the orbital margin maximum, undermining it and carrying out a suturing to close this, closing the tarsus, reconstituting the lateral canthus, and we have the complete reconstruction after the suturing is completed. And you can see that the margin is now aligned. We have a good lateral angulation of the lateral canthus, and we have the Colloboma that has now been repaired with the cilia bearing area, so which is ideal for aesthetic purposes as well. Now, before we go on to the other techniques, let us discuss some principles for flaps in eyelid reconstruction, because flaps and plasties are very important to know when we plan a reconstruction. Now, what is a flap? So this is Sushrut, who's the father of plastic surgery globally, and we need to be proud of that. And this is 600 BC. And when the nose was cut off for as a punishment, and the nose skin had to be reconstructed, so a cheek flap was what he used. And this is the principle that is still followed some 2,700 years later. So a flap is a unit of tissue that is transferred from one location to another location. So one donor site to the recipient site. Now this is done with an intact vascular supply. So let's look at the principles of flap surgery. Now, what are the principles? You should try and replace like with like. So if you are going to do the inner lamina, you will need a flap from the inner lamina with mucosal lining, a skin for skin, a thin skin for thin skin, thick skin for thick skin, wherever desirable. And think of reconstruction in terms of units, means this is the amount of square centimeters that needs to be replaced. And this is how we will stake. This is how we will construct, which will ensure that the vascular supply is intact. Say, for example, in a flap advancement flap, you would retain the ratio of 5:2. So if your length is 5, your base should be at least 2 in order to retain the vascular supply. Always have a plan, but when you end up creating the defect, when you think of a flap at that moment, you always need to have fallback options because you often need them. Now, this is again an important principle that to pay Paul, you are stealing from Peter. So think of the donor area as well. It's not that there is no price to pay in the original price. So see if you are able to repair the donor area once you are taking that tissue from there without causing any consequences in the donor area. Now, what are the advantages of flaps over grafts? One, they can carry tissues other than skin or mucosa alone. You often take a vessel along. So vascular-based flap, we will see superficial temporal artery-based flap later. So that is an advantage. You can have, of course, flaps of other tissues like, for example, we take fascia, we take muscle flaps. So all those are options. Say, for example, temporalis fascia used as a sling in the lower lid and so on and so forth. They retain their own vascular supply, which is a major advantage over a graft, and you can have the other lamina without an intact blood supply. So therefore, they can be used on a bed with questionable nutrition. Whereas a graft will require, especially a full thickness graft, will require a healthy bed. And in a graft, you need to ensure that the apposition is very good because the blood supply is to come from the bed. And therefore, you need a pressure dressing, which can be uncomfortable. But here, you do not need that kind of a pressure dressing because the blood supply is coming from the original side, not from the bed alone. So flaps, how do we classify them? That is important for us clinically. It's based on anatomical content. Like we have the skin flaps, sometimes we have the muscle or muscle with skin myocutaneous flaps. We have fascia and fascia with skin fasciocutaneous flaps. We have mucosal flaps and we have mucocartilaginous flaps. So all these can be used. And based on congruity, we'll see what the importance of this when we look at the different kinds of flaps. Local is from an adjacent area, as is obvious. Regional, not exactly adjacent, but from the same region. But you all have heard of distant flaps, which particularly plastic surgeons use from the arm for the face, where they keep the arm like this for several days. Radial artery we also use for socket reconstructions at times. So non-contagious or distant flaps can also be used. So that is important to remember. So let's look at the types of flaps. First of all, the local flaps. Now these are, we look at these terms and then we look at what they mean. Sliding flaps, advancement flaps, rotation flaps, transposition flaps, and another variety, the interpolation. We'll look at that as well. So sliding only implies that you have a defect like this. You undermine here, slide both of these tissues and bring them together, as you see here. So this is a sliding flap, which you consider as just mobilization by undermining on both the sides. Now, advancement flaps. So it's a simple linear advancement flap implies that you move it directly forward and there is a defect like this. You feel that this tissue can stretch to cover this entire region. So you take a much longer skin flap as a linear flap, undermine all these edges, move it and close it like this. So extra elasticity of skin has covered this. So this is a linear advancement flap. So we saw this example earlier. We have this defect here. So we gave these two incisions in the eyelids and we were able to move this because this was an older patient with enough tissue here which could be mobilized and which could stretch and cover this entire area. And we could then open the lid. This is a tarsoconjunctival flap below, which we open later and we have a well-constructed lid. We'll see this example later. Sometimes you can combine sliding and advancement flap. So you, of course, are sliding, but you also have given a little extension here, a little extension here in order to advance as well. So there was this sliding which you could do, but the defect is too large. So you've given relaxing incisions here and brought them together to do a combined flap. Now, tensils, we have already seen the example, which is again an example of an advancement flap, not really a rotation flap, as we'll see from the definition of rotation later. Now, rotation flaps imply that your rotation of an adjacent tissue is what you carry out. Look at this defect here. Now, this defect we've created into a shape where a rotation flap will fit in. So if this flap, this area of defect needs a little modification, we'll carry out. And then we give an incision like this so that this quadrangular tissue can be rotated to fit in here. This point here, this point here, and this point here. So we have constructed it like this defect. So this tissue can then be rotated to an adjacent area to complete a repair like this. So this is an example of an adjacent tissue being shaped and prepared to get rotated into the shape of the defect. Now, another variation is a simpler one. a defect like this, you give an incision like this. Here, it's not a linear advancement flap. Principle is similar, but here we are planning to rotate this and use that little elasticity to cover a larger defect. So this is the defect, this is the incision, and we rotate this, take this tip here. This is the area that is left raw, and you will be able to slide it and close it if you give it a little extra cut like this. Remove a triangle here, and you're able to get a defect like this. So this again is a rotation flap. So an example would be, this was a traumatic defect in the tarsus because of this. We thought we had enough tarsus here to be able to use it. So we gave a relaxing incision like this, rotated this down, and used it here. It still provided us enough tarsus to support this lid, and it came down right up to here. So we were able to rotate it and repair, close it here, so that we had this, and then we could put a skin graft on top of this, and we could close it. So the rotation, tarsal rotation flap. Now, what are the transposition flaps? Say, for example, this is the defect. Here, you're not rotating it, you are not sliding it, but you are turning it laterally to reach the defect. Say, for example, this is a square or a rectangle. We've given in a sliding flap, what you would have done is created a thing like this, depending on whether there was in a flap which we were moving further, we would have given incisions here and moved it here. But if there is no tissue here and we have tissue here, then we'll need a transposition. So we make a flap here, rotate this here. So this becomes a transposition flap. Now, again, I'll repeat the defect here. So we are not rotating, we are not moving it forward, we are rotating it at an angle. So flap from this direction, rotated it. This flap, lifted up, this tip goes here, this goes here, and we have this closed here with a little excision of a little triangle. We are able to get a complete closure. So this is a transposition flap. So examples of this are a Trippier flap, which is used from the upper lids where there is enough lax upper lid skin for the lower lid. Prepare this flap. There is a defect here. You'll rotate it here and put it here. So this is a clinical example of flap taken from here for a tumor removed in this area. We've used the tarsoconjunctival flap, and we have rotated this flap, which will take up the normal color in a short duration of time. So an example of transposition flap again is a superficial temporal artery base. So we have a feel of the superficial temporal artery, take deeper tissue as well containing superficial temporal artery and rotate it at the right angle to cover this defect here. So this is a transposition flap. Now, what is an interpolation flap? When it is from a nearby area, but not a contiguous area. See, the skin is present here. This is not a defect which is coming to the root of the flap. So this is a superficial temporal artery based flap again. We have intervening skin and then we are transposing it. So you can call it a transposition flap, but with an intervening tissue. We can go over the surface or go below the intervening skin to close this defect. So this is an interpolation flap. An example is this midline flap. That was a temporal flap. This is a midline flap. So midline flap with an intervening skin moved here to reconstitute both the upper and lower lid. So I think that really takes care of the principles of flaps. We'll briefly talk about plasties, and then before we go to specific repairs, we'll take up your questions. So for plasties essentially imply you are redistributing skin. And the examples most commonly used are Z-plasty and a VY-plasty. Now this is from that principle. a double transposition of flaps. We'll see this. And VY-plasty is really an advancement flap. So if you have a line of scar tissue, let's say this is the upper lid, you have a line of linear line scar here, so that there is a shortening here. So what you would do is put a vertical line here and two lines at 60 degrees to that. So you have this flap and this flap. Now we have undermined. So we have a flap here and a flap here. If we rotate this here, and if we rotate this flap here, we will have a lengthening in this direction because of the structure of this AB. If AB was the length here, it will become equal to CD if this point is C and this point is D. So this will get lengthened to this length by rotation of these two flaps. So this flap goes here, this flap goes here. When we close, this area gets lengthened on this linear shortage is taken care of. You can also use it besides lengthening for reorientation, like this downward shifted canthus. We want to rotate it upwards. So what do? We constitute a Z like this, lower limb here, upper limb here. We rotate the lower limb higher and we bring down the upper limb down. So this is what happens. Upper limb has come here, lower limb has gone up. So our medial canthus has become better position. So this is what happens with the Z-plasty. So there are other uses besides lengthening. Now VY-plasty, let's look at the example. We have a linear shortage here. So given an incision, this skin is really short. So when we remove all the scar tissue from the bottom and we undermine it, you will find that the lid will go back to normal position because all the pull has been negated now. And all the bed scar tissue is being excised. You can see already the margin is very relaxed. So if you remove all the scar tissue, the lid margin will come back to normal position, already normally positioned. Now we need to mobilize tissues. It is a plasty. We are just using the tissues around. So we are moving this tissue here to close it. So this tissue has been used to give an elongation in this direction. It has shrunken to this position, leaving this area raw, moved from here, closed like a Y, and you now have correction of the ectropion here. So what happens? You have a linear shortening here and a much larger shortening here. So you needed a VY-plasty for the upper lid and a graft for the lower lid. And the correction, you see the pull is now gone. This is relaxed. This pull is gone. This lid is relaxed. So we spoke about Trippier flap earlier. We will talk about the other flaps used in reconstruction. But before that, we can take up your questions before we go on to specific techniques in the reconstruction, just for the principles of flaps and reconstruction. Any questions from the audience? If Dr. Namrata or Dr. Lakshmi can see.
On the Facebook, there were no questions. I'll just check on the YouTube also if there are any questions there. Dr. Anand, can you post them please on the chat?
I'll do that, ma'am. Just give me a minute. I'll check if there are any more questions.
I have a question in the meantime.
Yes.
This has been very beautifully described, sir, step by step. It's very nice. Interpolation flap, you mentioned that you will keep intervening skin in between. Now, and you also mentioned that we can bring the flap above the skin or below the skin. So how do you tackle both the situation? When we go above the skin, how do you manage in the second sitting or the later stage? And when you go below the skin, how do you manage?
So interpolation skin, you're not leaving an intervening skin. You are just choosing to do that because there is intervening skin in between. So you are requiring a flap from an area where you can take it. And because there is intervening skin, it becomes an interpolation flap rather than an adjacent flap. Then we would have called it a transposition flap. Now, there are advantages and disadvantages of going over and going under. Going over is much simpler, does not require dissection. So you just place it there and then you release it. We'll see a video later of how you relieve it, and that will clearly explain what you do with these flaps. In the deeper ones, the advantage is it is much more fixed, much more snug there, and also has vascular supply in the meantime, and therefore it is much more secure, but requires a little more technical dissection. Either one is acceptable, and they're commonly used. In fact, these interpolation flaps are often used not from the same side. Say, for example, if there's a defect on the right side, you can take it from relatively on the left side because that gives a much better rotation, a much less angle of rotation, acute angle of rotation. So it becomes that much easier for the blood supply to be retained.
So would you, if you go above the skin or below the skin, would you like to debride a little bit of, with a debrider, would you like to debride the epidermis?
No, you just let it be there. The deeper surface of the graft heals on its own. When you put it back, then you maybe draw it a little bit.
Okay. Now, if you're going below the skin, if you're bringing the flap below the intact skin,
Yes.
Then would you want to debride a little bit of the flap skin?
No, we don't need to do that because it stays intact there. And because it is
because the skin is coming underneath the existing skin.
Yes, but because it is a temporary thing, it will be there only for 4 to 6 weeks. It will come back to its original position. We want it to retain its normal intact situation.
And the other very important point is about the ratio. Is it, some books say 1:4. You mentioned 2:5. What is be the correct?
So 1:4 is usually intact, depends on the vascular supply. But to be on the safer side, we're saying 2:5, 2:6, 1:3. 1:4 is often sufficient in areas such as face where there is a good vascular supply. But to be safer, keep a little broader one. Try not to compromise too much on the vascular supply.
So just to recognize the fact that Dr. D.P. Vats is also watching, and he's saying that I'm enjoying homecoming after a long period. So
welcome, MP Saab. Great to represent us in Rajya Sabha.
Yeah.
General Saab.
We
Thank you. Thanks
move
for
to
being
the
here.
next part of it, sir.
Okay, so we'll go to reconstructions again. Can you see the screen? Is the screen visible now?
Yeah, it's visible.
Okay. So now another example for Z or VY plasty where we have this linear shortage here corrected by Z in order to give the correction here. So let's look at the utilization of these flaps that we spoke about. Now we spoke about the Trippier flap, which is used from the upper lid to the lower lid. A freak flap is one which is used from the forehead for either upper lid or lower lid like this. So these are examples of skin flaps. Let's look at a clinical examination, clinical example of a Trippier's flap. So we have a tumor here. We have excised that tumor and we have this defect here. Now, we are using a tarsoconjunctival flap from here and moving it down. We have repaired that. And now we have skin flap taken as a Trippier flap here. So this is the tarsoconjunctival flap which has repaired the inner lamina. And this is the Trippier flap which we have here, which is correcting the skin part of it. So we have both laminae corrected by flaps. And once we have removed this, we have a well-constructed lower lid all with flaps with no graft having to be used. And post-operatively, therefore, the healing is very nice. Both the laminae are well constituted and the closure is very nice. Now let's look at some of the lid sharing procedures. What is the advantage of all these sharing procedures? The eyelid tissues provide the best match. Say, for example, inner lamina tarsoconjunctiva is similar to tarsoconjunctiva. Skin is very similar to the skin of the upper lid. Both laminae can be repaired in sharing procedures, and the procedures are very versatile, especially this tarsoconjunctival flap. It can be mobilized laterally, it can be mobilized medially, it can be mobilized obliquely, vertically. So all laminae can be repaired. All portions of the inner lamina can be repaired with the tarsoconjunctival flap. And these tissues with time stretch adequately to prevent any defect at the donor site. So this is the advantage of lid sharing procedures. But there are situations when you need to avoid, like infants and young children, where you want to avoid amblyopia and tissue laxity is often not adequate. If the opposite lid has had a surgery earlier and scarring, then again, you may not get enough tissue. And the caution that was given by Mastade, that if you are using for a lower lid defect, be cautious when using upper lid tissues like this, like we are using for lower lid, a lower lid flap of tarsoconjunctival skin. Do this cautiously. Do not compromise upper lid too much. Let's look at the tarsoconjunctival flap. Now, tarsoconjunctival flaps, as we said, have the advantage, or Hughes flaps have the advantage of being very versatile. It can be used for lateral canthus, medial canthus, for the lower lid, for the upper lid, and I use it very extensively. So let's look at an example. This is a tumor, a meibomian sebaceous carcinoma. So we need to excise with a 5 millimeter zone, 4 to 5 millimeter zone. We are doing an excision after having marked that zone. Again, a patient presenting late, so we have a huge defect. So we have very limited techniques. We have the canthus also involved. And once this defect is outlined, we find from the frozen section that there is still some tumor. We'll excise that, get a clear report. Now we are outlining a tarsoconjunctival flap. So we leave 4 millimeters so that this area vascular supply is not compromised. Create a flap, anchor it here. Now this suturing has to be done meticulously. We can skip that. And once that suturing is done, you also make sure it is covering the lateral area well, medial area well, lateral canthus is well reconstituted. And then we do a good anchoring of the flaps on all sides. And then we have mobilized the flap from the upper lid. This is that case where we outlined the principle of moving the tissues from as an advancement flap. Now, once we are excising in the second stage, make sure you have excess mucosa, because you want the margin to be constituted by mucosa. So take as much excess of mucosa over the eyelid to reconstitute the lid and reconstitute the lateral canthus so that you have an adequate repair. Now you can see that this huge defect has been repaired well with mucosa constituting the margin. This will of course become inconspicuous later. You have a well constituted lid which is closing well as well. Now basal cell carcinoma of lower lid here. This is another example of a large defect involving the medial canthus. The medial canaliculus is also involved, so we have marsupialized it, and we have sent for frozen section, made sure that there is free edges, and then mobilized a tarsoconjunctival flap and repaired this area, and also used a Trippier flap to close this area, and a good reconstruction is obtained. An example of Cutler beard flap. Here again, we have a tumor in the lower lid, in the upper lid here, which we have excised. This is the excision, this is the defect. And now we are taking both lamini. So leave 4 millimeters here. If this is the defect, you can take this a little smaller. If this is 20 millimeters, you can take it 1/4 less, maybe 16 millimeters or so. So you prepare the flap with a 4 millimeter margin. This area needs to be left with intact marginal plexus, which is at 2 to 3 millimeters for it to survive. And then 4 millimeter full thickness incision, inner lamina mobilized and sutured here, and the outer lamina mobilized and sutured here, so that this is a complete closure. Then you wait for 4 to 6 weeks, 6 weeks generally, for the complete healing to take place. And this is the handle that you are left with of the Cutler beard technique. Then you open it up, take excess mucosa. This is the upper lid and lower lid, and we carry out a repair of the lower lid once again. Make sure we've reconstituted the upper lid as well. So this is at the end of the surgery, and this gives a good reconstruction. In this infant, we've done an upper lid reconstruction, and we have been able to use this. A lid sharing technique could be used because cornea was already opaque because of the previous exposure keratopathy. Example of Mustardase repair, a huge sebaceous carcinoma again, excised, and then a full thickness rotation of the lower lid tissue. We have outlined it here and rotated it here as a full thickness lid, which gives you the lashes as well. So from the lower lid closed by direct closure. So these are the techniques which are used in most cases, which we've outlined earlier. But sometimes you have many even more challenging cases with complete defects, more than 2/3 to near total defects. This is where we need all these flaps, such as midline or glabular flaps. Glabular means within this area between the lashes, and midline means all the way up. And or we spoke about the superficial temporal flaps on the outer side. But then you need to, when you have large defects, combine with posterior lamellar grafts, either tarsoconjunctiva or mucocartilage. And which is rarely used now, the traditional Mustardase flap of rotating the lower lid to upper lid and reconstituting the lower lid with a cheek rotation. So these are the techniques that are used for larger defects. So firm support, as I said, is essential. You need to put in tarsoconjunctiva as well, which may be taken from the opposite eye, or tarsoconjunctival flap we've already spoken about, and nasal mucocartilage is frequently used. So this is a Mustardase cheek rotation flap done long ago. I don't do it any longer. Huge rotation for a nearly total lower lid defect, and combined with a nasal mucocartilage taken with the help of an ENT surgeon. Not that difficult. We can do it ourselves. Periorbital flaps, the sebaceous carcinoma here, where we're using a sebaceous superficial temporal artery-based interpolation flap. We look at this in this video because it highlights some important principles, including the lateral canthal repair. So let's look at this video. Now, this is again a huge tumor, so 4 millimeter margin being measured, excised, frozen section control is essential. Now the lateral canthus is totally involved, injecting some xylocaine with adrenaline to decrease the bleed, excision. So these are the clear edges. Huge tumor, as you can see. We are checking the intactness of the conjunctiva, the rest of conjunctiva, remaining levator tissue, which we will all need. And then we are mobilizing the tarsoconjunctival flap, as you can see here, which we are using to repair the internal lamina. But we will make sure that we anchor the remaining levator to this tarsoconjunctival lamina that we reconstitute. So now the inner lamina reconstruction is complete. Levator is being identified under the preaponeurotic pad of fat, which will be re-anchored back to this particular tarsoconjunctival flap. And then we are putting back the lateral canthus. Now, you have to make sure that you take this anchorage from the Whitnall's tubercle, starting with a bite on the inner aspect and using a suture material like Proline, which will hold this tension and stay for a long time. And now we are taking our interpolation flap. Superficial temporal artery is felt, and we take a flap. We're feeling the artery and taking the flap, which will then be rotated. We're doing some cryo of the remaining area where we feel the edges of, there may be edge tumors that can be killed. And then this flap is being sutured back. We have anchored the levator aponeurosis here, and we are completing the closure. So once this closure is done, we are undertaking the second stage. 6 weeks later, we'll see how we open it. So again, opening it with an excess of mucosa, the principle that we have outlined earlier. This time it can be done under local anesthesia. And we are now opening it up with an excess mucosa and will reconstitute the margin. And then freshen the edges. Now these edges need to be freshened for them to heal well when mucosa is sutured to them. And then suturing is carried out. And then the remaining tissue is put back in the lower lid and sutured there. So the lower lid repair also needs to be completed. Now, what do we do with the remaining tissue that Dr. Lakshmi was asking? So whatever we have to use, we use that and excise the excess. Whatever needs to be put back will be put back. Whatever extra stretching has taken place can be sacrificed. And now we have a well-constituted upper lid and the lower lid. For a huge tumor like this, adequate coverage. We can do a secondary repair if required to improve ptosis if the patient desires, but most of our patients don't. So example of excision with frozen section control of another one with tarsoconjunctival flap, superficial temporal artery blazed flap. Lastly, we'll talk about the midline flaps. Now, this was a patient who had a tumor for 7-8 years, a well-to-do patient, but she didn't want a surgery. She said, I will not get a surgery done. So she waited and waited. When she came to us, we told her that this is impossible. You have an upper lid, you have a lower lid, you have the inner canthus. The whole upper and lower lid is virtually gone. So this is irreparable. Go ahead with biologics. So once she went and found out the cost, which was about 10 lakhs or more, she came back and said, no, I'll get the surgery done. So giving us an impossible task. So this was the excision. We excise all this, and now virtually the whole of lower lid, upper lid is gone. So we are at the crossroads, how to repair it. So then we took a nasal mucocartilaginous graft. This is what we have for the upper lid. This we felt there'll be enough in a lamina. And both this and this need to be reconstructed. So we took a broad midline flap, use that to reconstitute. We thought coverage is important. We may not get it aesthetically very right because medial canthus cannot be reconstituted very well when this is all involved. But a second stage surgery can help. And even this is not adequate. So we will also need a skin graft in addition. So this is what we did. We repaired the medial canthal region with that. Use some skin graft here, and then we open in the second stage. So we have this well-constituted upper and lower lid. We need to repair the medial canthus again, open it up again. She hasn't come back for the second stage surgery. If she does, we'll do it. So lateral canthus principles we have already outlined. Whenever there is a break, reconstitute with 40 Proline sutures and require a permanent suture like Proline to anchor, which we've seen in trauma management. Example is this melanoma with lateral canthal defect, where we have done an anchorage and created the lateral canthal flap. Another basal cell carcinoma involving the lateral canthus, repaired with a tarso-conjunctival graft here for inner lamina, and the lateral canthus is reconstituted. Important to maintain this angulation well and to anchor it well on the lateral side. Lastly, again, medial canthus, re-emphasizing the principles of medial canthus, the question that was asked. Medial tarsus to be fixated to periosteum near the posterior lacrimal crest. So whatever you take, tarso-conjunctival flap for the inner lamina, skin flap or graft for the outer lamina from various places, ensure that medial canthal anchorage is good. Sometimes smaller defects can be left for spontaneous granulation. This was a technique popularized by Dr. Mehta from in Wales and was very popular for small defects, gave a good repair. So outlining the principle for the question that was asked, medial canthus reposition. So give an incision through the conjunctiva, go in a backward direction medially till you go behind the sac, identify the bone there, and do an anchorage on the periosteum with a Proline suture, and then pass it through the medial canthal tendon in very close to the tarsus, and then tighten it. You are able to get a deep positioning. So exposure through a precurruncular incision is important, and then you can get a good anchorage. Now for the difficult cases, you may need either transnasal wiring or what is much more popular is low profile mini plate. So all those cases where there is bone loss, you identify the area, get some bone there. If there is no bone, you may even need to put a little graft there and put a mini plate with small 2 to 4 hole plates and small superficial 3 millimeter or so screws to screw it in, and then pass your Proline suture around that screw to anchor the medial canthus. You screw the 3 millimeter screw and use that for anchorage. So this is an example here, telecanthus repair with plating. Example of transnasal wiring. This girl had bilateral telecanthus, bilateral dacrocystitis. We did a bicoronal flap with the plastic surgeon and then did a medial canthal repair here. I just put in the power supply. And we did an open sky DCR and put in a transnasal wiring to correct the telecanthus so that her telecanthus could be corrected very well with deep positioning of the medial canthus and dacrocystitis taken care of. She also had loss of vision, traumatic neuropathy, required a squint correction later, which has been done. So this can be life transforming for a patient to be able to live a normal life with normal aesthetic appearance as compared to this. So example of medial canthal avulsion repaired with reattachment, canalicular repair. Another example of medial canthal reattachment with advancement skin flap. So to conclude, eyelid repair needs to be customized based on the properties of the eyelid defect. So you need to evaluate well, prepare a plan A, prepare an alternative plan, and then carry out the repair. Partial thickness defects are repaired by simple closure or flaps or grafts. For full thickness defects, you require repair of the anterior lamella and the posterior lamella with an appropriate structure based on the size and shape. Precise reconstruction of lateral and medial canthus is critical. So a versatile combination of techniques with sound knowledge of basic principles and thorough adherence to them is the key to success in eyelid repair. So you must know a variety of different ways of doing things to choose the most appropriate one in a given case. So you need to often take the road less traveled in these difficult situations, which makes all the difference to the management that you do. Thank you all for your patient listening. Would be very happy to take up any of your questions. Dr. Lakshmi, please, your comments.
Thank you very much, sir. All I can say, it was excellent, beautiful, very nicely described. Everything was very well thought of. You had appropriate videos, and it just shows what a vast ocean of experience you have, and thank you so much for sharing with us. At the outset, I would like to thank Namrata for this beautiful initiative, because and AIOS, because in conferences we don't have such time to interact and learn. We just fleeting 10-15 minutes talks, it's we're just galloping like a horse. So this is a very refreshing, welcome series of lectures, and I hope we have many more in oculoplasty and orbit for the benefit of all. Now there are about 3 to 4 questions. Dr. Anand Sethi has once again raised the point. He's asking one. Dr. Mehta sir is asking, which is the best suturing material for eyelid tear? Which is the best? He wants to know in a gist, probably.
Ideally, a non-reactive suture. So monofilament suture like nylon does very well. Many people would use Proline as well, but Proline has the disadvantage of being very stiff, more difficult to handle, and the knots sometimes tend to open. So handling wise, 6-0 nylon is very good. Sometimes 8-0 nylon if you're working with a magnifying device. So those give excellent results. For the margin, somehow silk has the advantage of being braided and also being very soft, so no injury to the cornea if it gets exposed. But otherwise, 6-0 nylon is usually my material, along with 6-0 Vicryl for tarsus, and for any other deeper suturing, I would use a Vicryl. But many times in children, you would end up using, if you have a plain gut, that would be a good material because you don't want to work hard on suture removal. So that way you can sometimes use plain catgut in children.
What about using a silk in the subcutaneous plane? I have seen some very accomplished
Cuticular closures,
but they say even for frontalis sling, I have seen them use. Would you prefer personally a braided material for subcutaneously? That is my question. Second is, which is the best suture for the Indian skin? I say it's nylon. What do you say, sir?
I agree. I would agree. Nylon works best, leaves behind virtually no mark. We used to talk about a lot about subcuticular closure of straight wounds and so on and so forth. We realized there's no mark ever left of any sutures once you remove them within a week. So,
even
and
after
if you
a month also sometimes.
Yeah, and with your nice, sometimes continuous sutures of eyelid injuries or eyelid incisions, there is never any track of sutures. So subcuticular was a waste of effort. We no longer do subcuticular.
So there's another question now. Dr. Prashant Reddy wants to know whether when there is a straightforward cut, do you prefer subcuticular suturing or an interrupted suturing?
So if it is a linear cut, you can, and there is no tissue laxity at all, sometimes the continuous suture does very well. But in trauma, many times you are also worried that sometimes there may be more reaction, sometimes an infection. So interrupted in trauma would be good. Surgical wounds, I would very often put a continuous suture. Using nylon, using 6-0 nylon, that would be my go-to suture for these cases.
What about subcuticular? I feel there's no need. What is your opinion?
Yeah,
he wants to know.
We were very happy to make videos with subcuticular sutures earlier, but we realized it's not necessary at all. There is no suture mark. It was basically to avoid those skin suture marks, but there is none left after a week when you pull out a continuous suture or even an interrupted suture. And there is no need for subcuticular sutures on face.
Eyelid skin is very forgiving that way.
Very forgiving, and we are blessed to have those that skin where healing occurs so beautifully because of rich vascular supply.
Dr. Ashish Shah has two questions. One, he wants to know about, let me go, I just wrote the gist, but better I read it out. How do you manage flap failures, he wants to know. And his second question is, how to create a canaliculi in all new functional eyelids.
Okay. I read that
question.
question.
You're replacing the entire eyelid is what he wants to know.
Okay. So first, the flap failure. Best way of managing them, prevent them. So take instead of 1:4, maybe take 2:5, so that you have rich enough vascular supply. But sometimes some reasons like maybe tension, maybe hematoma, maybe an infection can jeopardize them. So then you manage them according to the situation, whatever the cause is. If there has been an infection, loss of flap, then you let it heal for a while. Once the infection is over, once the secondary healing has taken place, caused a contraction, do it as a secondary repair. Maybe will require a graft to be placed in that region after the settling of the inflammation, and doing a secondary repair at the end of 6 months or so when it can be done. Of course, circumstances in individual cases may be different. So whatever the cause of the failure, it will need to be tackled accordingly. Now, as regard the question of creating a canaliculus
in an all new functional new eyelid, which you have reconstructed.
Yeah. So if you recreate an eyelid, you do not have a canaliculus, and it's not easy to create one. There is a friend of ours in Switzerland who's been making synthetic ones. He's trying to work for artificial canaliculi for over a decade, but it hasn't yet come about. There will be materials which will come about, which can be anastomosed to the remaining passage or something over a period of time, but not yet. So for the moment, the go-to procedure at the end of it, if there is enough epiphora, is to do a conjunctivodacrocyst or rhinostomy or a Jones procedure. But that also can be avoided in most cases because the other canaliculus is functioning, and also because you can sometimes use an injection of botulinum toxin 2.5 units in the lacrimal gland, which often takes care of the remaining epiphora. And sometimes with 2-3 injections, you are able to permanently get the production down to a little lower level, which is compatible with functioning. I can recall very few cases, maybe just 2, where I've actually, after a lid reconstruction, done a Jones tube. So almost all of these cases can be managed satisfactorily with our conservative needs.
And moreover, when we are reconstructing so extensively for tumors, we would be a little worried about dissecting in the lacrimal region and taking it or into the nasal mucosa. We would want to avoid a further medial spread, isn't it?
Particularly as a primary procedure. Maybe 6 months later, once you are sure everything is healed, you can think of a secondary procedure.
Dr. Ankita Aishwarya has 2 questions. She wants to know, Shazad sir, how do we remove the Proline suture post medial canthal repair at the posterior lacrimal crest after 6 weeks?
So, as I said, the repair is by anchoring the medial canthal tendon posteriorly behind the sac. Whatever means you may like to use, either Proline suture or mini plate, micro plate. Now, a question is, 6 weeks later, what do you do if it's the primary procedure, you were not able to anchor it? So again, it'll have to be the same procedure. You'll have to expose the area of the posterior lacrimal crest and carry out a fixation. either by a suture or by a mini plate. It will have to be the anchor. In many cases, if you are able to compromise that you can't get it adequately posteriorly and you need to compromise and do a good anterior MCT tightening, sometimes you can compromise. Dr. Lakshmi?
She has another question. In a case of complete facial burn, how do you tackle the severe cicatricial tarsal ectropion?
Okay. It's a difficult situation, yes. Two measures. One is the immediate period when you are dealing with an exposure keratopathy caused by an acute burn. So you try and get as much of a tarsorrhaphy as possible. And if you need to, then put a epidermal graft as large as possible by removing all necrotic tissue and try and get a closure of the eyelid. But you're talking about the late situation where a tarsal ectropion has developed. Now, tarsal ectropion usually implies that here we are not talking about the usual age-related tarsal ectropion, but a tarsal ectropion that has been caused by shortening of the anterior lamina. Of course, it would be combined with the laxity that occurs with prolonged outturning of the lid caused by cicatrization and keratinization changes on the inner surface of conjunctiva, which would have secondarily taken place. So here, you often need to do a combination of techniques like you would do in all tarsal ectropions. One, you of course need to replace the skin, which will be by an epidermal graft because you are going to need a large size of it. So you can take it from the thigh if you want to, or inner arm if that will suffice, and put in an epidermal graft on the skin surface. But you may need to combine it with a little spindle removal of conjunctiva on the inner aspect and inverting sutures. Inverting sutures often need to be combined, and when you excise little spindle, you're trying to reattach or plicate the lower lid retractors as well. So take deep sutures so that you cause a turn-in by removing that spindle, and which is the keratinized tissue that you have removed, and take a deep bite so that you are tightening the lower lid retractors, which is a second procedure. And the third procedure will be the inverting sutures. Inverting sutures, the principle is that they are closer to the skin on the outer side and closer to the margin on the inner side. So those 40 chromic catgut sutures would additionally be put in 3 pair of double arm sutures, which will cause an inversion. So this inverting sutures combined with spindle excision, tightening of lower lid retractors, and cicatricial ectropion correction by skin grafting is what possibly you would need. Of course, it will have to be individualized in a given case, depending on laxity, whether you want to shorten the lid or something in addition, lateral tarsal strip procedure or something. So those are all combinations which will be individualized. Dr. Lakshmi, anything to add on this? You are muted, Dr. Lakshmi.
In acute burn, we mainly worry about skin. We don't worry about the tarsal plate initially, isn't it? Because we just need a cover there.
Yeah.
Support we think of later.
Yeah.
So in that case, we can take a split skin graft, isn't it? Because here we can't harvest food. We may need a lot of skin, so we better go in for a split skin graft in the initial stage.
And even the bed is not healthy enough to take any full thickness graft.
Now, Isha Garg has a question. What other post-laminar graft can be used for lower lid apart from upper lid? So I think she means posterior laminar reconstruction.
Yeah. In the lower lid, you normally have only about a 4 millimeter strip of tarsus in most of us. So if you have lost less than half of the lower lid tarsus, then you can do without a posterior lamina replacement. Most often, I have needed additional replacement mainly in upper lids. Lower lids, usually they do well even if 2/3 of the tarsus is lost. But if you have to, then tarsoconjunctiva is the best material. So from the opposite upper lid, take a free graft. Other than, of course,
He
tarsoconjunctival
wants to
flap.
know, apart from upper lid, the other
Then-
options.
Opposite upper lid. Now, one is upper lid of the same side, sharing. But from the opposite upper lid as a free skin graft, as a free tarsoconjunctival graft, leaving behind 4 mm of the margin is one choice, or alternately a nasal mucocartilage. Both of them are good options.
And you can
Sometimes,
also use
yes, ear cartilage, and what I have been using quite often now is the support and mucosa that we get from hard palate. Hard palate graft again is a very good option.
Ankita has a question again. Sir, can we leave Proline suture intact in the posterior medial canthal tendon repair?
Yes, for all buried things, you do often leave behind lateral canthal repair, medial canthal repair. Proline is totally non-reactive and permanent, nearly permanent. So we can leave it in without any reaction.
Perfect. Any more questions?
No more questions, ma'am.
Spirited youngsters. Okay. I think that about sums up the whole thing. It's been wonderful, Dr. Grover, sir. I have actually made so many notes. I have learned more than what I could interact.
That is your humility. And
No,
I
no,
know
it's
that
not humility, it's the truth. I can send you screenshots of the papers.
and we all learn a lot from you, especially your humility, your love and affection for everyone. That is an example for everyone. And I would take this opportunity once again to thank the All India Ophthalmological Society, particularly the Secretary and Dr. Namrata and Dr. Rajesh Sinha for giving me and Dr. Lakshmi this opportunity to interact with a lot of interested audience. Would like to thank the team of AIOS, Mr. Kripal, and his entire team, and the technical team, Anand Sethi and his team, for an excellent transmission and an excellent organization. Thank you, Namrata. Nice to see you. Get better soon.
Yeah, thank you so much.
Namrata, thank you so much.
No, sir, it was truly a master blaster class, and we could have asked for more. It had everything on the topic covered. I think after this master class, nobody needs to actually see anything else. And all the questions, the audience was so interactive. The questions were there. And thank you, Dr. Lakshmi Mahesh, for doing the honors and for, taking all the pertinent questions and doing a great discussion. Thank you so much.
Excellent anchor. Excellent anchor too.
Really thank you, Namrata. This is a very, very, very nice initiative. You have taken so many leads and a wonderful initiative by you, and hope you get well soon. I thank Dr. Rajesh Sinha also for the kind introduction and for all his interest and interaction here in this morning's session. Thank you, Dr. Rajesh Sinha.
Dream team at AIOS working very hard for all the endeavors of society.
Thank you.
Lovely.
Thank you so much, sir. Hope to have you again on another masterclass, and we hope to have Dr. Lakshmi Mahesh on yet another masterclass in oculoplasty. So thank you so much, sir. And we would like to thank our...
Thank you, everyone. Bye-bye.
We would like to
thank you.
and
Thank you.